Hey everyone, this is Amanda Moore from the Angelman Syndrome Foundation, and you're listening to the ASF Podcast, the show that explains everything you want to know about Angelman Syndrome. We're so excited you're here, and we hope you enjoy the show. For this week's podcast, we have repurposed a webinar that was recorded in years past, but the information is still very much relevant today. We hope this information helps you on your journey. Enjoy the listen. Welcome, everybody. We're so excited to have you guys here on a Friday night. Thanks for joining us on a Friday night. We're happy to have you, and you don't want to miss this one. This is the one that all of you have been waiting for throughout the week. We're incredibly excited to have our dear friend and our amazing expert, and one of the people that I admire so much, Dr. Ron Thibert, here with us tonight to talk all things seizures. Also, we have our awesome clinic director, Liz Gilazzo, back with us tonight. We have heard how much you have enjoyed her moderation, so she's got a second career here if she wants to be a moderating of panels. So we are so happy to have you guys back. And before I kick it off and pass it on, just want to remind you guys, for those of you who have joined me every single night, you're going to get sick of hearing it, but maybe it'll make you guys actually go do it. Sign up for the Express Feedback for Good. All you have to do is text ASF to 90412 and give your feedback. As of today, we had 550 people sign up and over close to $20,000. So we're close. So now it's all about giving your feedback. So $50,000 that could be ours. And Dr. Thibert knows for clinics, $50,000 goes far, right, Dr. Thibert?
It sure does.
Right? So get on those phones and start giving that feedback. But I'm going to stop because we want to have as much of this hour as possible to talk all things seizures. So I'm going to pass it on to my dear friend, Dr. Gilazzo.
Thank you, Amanda. I am thrilled to be here tonight with my great friend, Ron Thibert, to talk about all things seizures. We're going to do a similar format that we have done the past couple of nights, where we are just going to open it wide open for questions. As a reminder, the best way to get your question answered is to put it into the Q&A box. Additionally, you can use the chat box. If you raise your hand, we'll redirect you to the chat box or the Q&A box because we don't know how to unmute people. So without further ado, let's just jump right in and get started. So before I start taking questions from the crowd, I know most of this community does not need an introduction to Ron Thibert. Most of you know who he is or you've heard about him. But I'll give you a quick second to introduce yourself to the community, to those newly diagnosed parents who may not know you yet.
Oh, sure. So we have Angelman Syndrome Clinic at Mass General. It was the first one that opened back in 2008. And it sounds crazy, but we've seen about 350 families so far. So been doing this for 13 years and seen a lot of people, seen a lot of seizures. And, we've, on top of having the clinic, we've also done some clinical research and published on various things that we've seen over the years in our clinic. And just having a number of families that big, it's allowed us to do a lot of stuff that can't really be done other places. Just because we've seen so many people, we can really, we really see a lot of like patterns and things that kind of pop out and haven't been explained in the literature so far. So that's been one of the really kind of rewarding things about the clinic, is that we've been able to not only see families and help them individually, but also just learn a lot and be able to share that with other clinics.
Yeah, I am not going to let you off the hook with blazing right past your research. I'm going to get back to some of those important findings that you guys have published over the years, and particularly some of the more recent research around EEGs. So let's go ahead and get started. Before questions start coming in, I'd love for you to give, again, kind of thinking about our maybe more newly diagnosed patient population, kind of an overview of Angelman seizures. In the early days of after diagnosis, that waiting for that first seizure can feel like just the weight of the world. That creates a lot of anxiety. So help our families understand kind of when those seizures might start, what those seizures might look like. How do you know if your kid's having a seizure, and what should they do if they're worried about that?
Right. Yeah, that's a great question. So that's probably the scariest thing. And that's when we meet new families, that's always the biggest worry, even though there's lots of other things that come along with it. That's the one that really sticks out. One of the things about seizures is it depends on what kind of genetic type you have. Kids with deletions are at much higher risk of having seizures than other types. It's over 90%. But people that have the UBE3A mutation, or they have the two of the dad's chromosomes, they're more in the 2/3 to 3/4 range. And then the ones with imprinting center defects, which is the mildest, they might have probably 50% or less chance. So really depends on what kind you have. And then and within those groups, there's a lot of variation. Even kids with deletions sometimes will just, if they do have seizures, they'll just have occasional seizures. Some can have very frequent seizures. So it's even though it's the same genetics, the same gene that's not quite functioning, that there's every kid's different, and there's always differences. But for the kids, especially kids with deletions, that is the most common. We often see seizures start around 2.5 to 3, sometimes a little bit earlier. It can be a little bit later, but it's usually in right around preschool or before preschool. And the first seizures often come with fever, not always, but that's the most common time to have a first seizures with fever. And the ones that we think about as you would call them generalized tonic-clonic, some people call them grand mal, or those are the ones that that you kind of think when you think of a seizure. It's eyes rolled back, everything's shaking, drooling a little bit, but that's often not the first seizure that you'll see. It's usually more subtle, and so they're a little bit harder to pick up. One type is called what we call atonic seizures, or drop seizures, and so it's gonna be quick little head nods. Or they can be full body drops, but basically you just kind of lose all your tone, and either the head or the whole body drops. And those can easily be mistaken for just being sleepy. Some kids will get tired and they'll start to kind of nod off, and it can be anxiety provoking. But a drop seizure is really fast, and it's an immediate head or body, just all the way down. There's usually some kind of almost like a startle, it kind of scares them. They can be upset afterwards. So so that's kind of the best way to try to kind of differentiate that from just a sleepy kid, which we see all the time. And then another type that we see a lot that's hard to, that can be kind of hard to tease out, is called an absent seizure, atypical absent seizure. It's usually just staring. The kids may not be all the way unresponsive, but at least have altered responsiveness. And if it's just a few seconds and you kind of snap your fingers, you call their name, they turn around, then it's not a seizure. Those, they usually last, 10, 20, 30 seconds, sometimes longer. And it's just kind of a sustained period where they're just not really focusing. They're not responding to name. If it's just a couple seconds, that's every kid. And, if you can get their attention, that's obviously a good sign. And then the other kind we see is we call myoclonic seizures. So we all have myoclonus. Typically when we sleep, we all twitch. If we're falling asleep, sometimes you get that feeling like you're falling off a cliff and you jerk yourself awake. That's myoclonus. So everybody does it. Kids with Angelman syndrome do it more in sleep. But if you see big kind of twitches like that while kids are wide awake, kind of even big enough to sometimes knock them over, then that's very similar for seizure. There's another type of myoclonus that we see in older individuals, but we'll get to that later probably. But myoclonic seizures usually that can often be one of the first seizure types we see, and they usually are gone by age 8. When we looked in our clinic in this big group, and I think 8 was the oldest that we had seen it. So they a lot of these types come and go in childhood, but those are usually the 3 most common types that you'll see early on. The big ones are easy to spot. You fall backwards, you shake everywhere. But the more subtle ones are a little bit tougher. And another thing that comes along with it, if you usually don't just see 1 or 2. Once they start, they'll often kind of come more frequently. And if they are seizures, you'll see most of the time, you'll see a little bit of developmental regression, just things aren't quite as good. Balance may not be quite where it was. Sleep might be off. So there's other things that'll come with it. So if you're seeing these, either what you think might be head drops or staring spells, and there's just other things that are going on that just make you think that something's not quite right, then that's more concerning that seizures are starting.
What should families do if they're worried that their child might be having seizures?
Yeah, so I obviously, if it's a big seizure and it's the first one, a big shaking one, then either call 911 or go to the ER, because if it's the first one and it's big like that, obviously the first seizure is always scary, but if the first seizure is a big seizure, then there's a decent chance that there's an infection going on, and it doesn't have to be anything scary, just an ear infection or pneumonia or just strep throat, just regular kid stuff. But any kind of infection can trigger a seizure if they're about to start anyway. But if it's just some little head drops or some staring spells and you're not sure, the best thing to do is record them and then get them to your doctor and see what they think. Definitely, call, the neurologist or whoever you're seeing and let them know what's going on. But also, if you can get it on video, it's super helpful.
Yeah, absolutely. I think that's great advice. Well, I think that's really encouraging advice, particularly for our newer diagnosed families, that, I think parents often worry that it's going to be one of those big seizures like the type you see in the movies, but most of the time it's not with little kids with Angelman syndrome. Certainly not to say that it can't be, but that's not the most common first seizure type is what I'm hearing.
Yeah. And obviously we don't want them to kind of keep happening, but if they start and there's some head drops or whatever, they're it's more of an urgent issue, but it's not an emergency. If you call the doctor and they say, let's get an EEG tomorrow, and then we'll go from there. That's okay. Unless it's a big long seizure or they're just happening so frequently that kids aren't kind of going back to the normal selves in between. It's okay to, send the video, get the test, kind of go through the normal steps. So it's I guess the main point is that like a few little seizures like that they don't do any permanent damage to the brain. So you don't have to worry that there's any long-term issues for having those few seizures. Even if seizures get really uncontrolled for a while, once they get controlled, development can kind of slow down, go backwards, and seizures are in a state where they're hard to treat. But once you get back on track, that development kind of comes back and catches up.
Great. That's super reassuring. So a few questions that we get all the time. If in this scenario of like a first seizure, is it necessary to get an EEG? How long does that EEG need to be? Does it need to be a 72-hour EEG? Can it be a quick clinical EEG? And what happens if we don't catch the seizures on the EEG?
Yeah, and that's a really good question. So the EEG, there's like you said, there's two options. There's the regular one that lasts for 40 minutes or 40 minutes to an hour. Then there's the ones that the take home or the stay in the hospital 24 to 72 hours. And it depends on the question. If there's events that aren't really, it's really not clear if there's seizures or not. You look at the video and you say, I really don't know if that's a seizure. Then we want to do the long one. We want to catch some events. Kind of the gold standard is if you catch the events and you'll see on the EEG it's either a seizure or it's not. Like we'll be able to tell. And even if we don't catch them, if there's seizures that we suspect and the EEG shows abnormalities that kind of tell us there's an increased risk of seizures, then kind of the two put together are a pretty good story for seizures. If if we see the video and they're just obvious seizures, we know they're seizures, we'll just start medicine and usually just get a routine EEG just so we have like a baseline to kind of compare that to moving forward. But if we know there's seizures, there's no need to get 2-3 days because we kind of know what's going on. The other reason to get a longer EEG, even if we're in that situation where we know there's seizures, we know what's going on. If kids just don't seem right, if they don't seem like they're at their baseline, if they're like I said, their balance is off or their communication's kind of gone backwards, then it's important to get an EEG to and often the short one will tell us, but sometimes you want to get the longer one just to see if there's something called non-convulsive status. And that's basically just a super long absence seizure. Like the EEG is just kind of showing either constant or near constant spikes. And even though it's, you might not be seeing clinical seizures, you might not see like drops or staring spells. There's, this constant kind of spiking on the EEG leads to, kind of the development falling off, the, just things they were doing, they're not doing as well, balance, coordination, communication. And so we have different treatments for that. But similar to the just having frequent seizures in general, those regressions, those kind of going backwards, it's also temporary. You know, we treat that and then it gets better. So kind of no matter how scary things look, when you see things that just aren't the same, they're not, you know, the development's going backwards. You feel like you made all this progress with therapies, and then it's just kind of taken, you know, like 6 months have gone backwards in a week or two. As scary as that is, that stuff will come back when the EEG is better and everything's back to where it was.
I think that's helpful to allow parents to just take a big deep breath when this is going on, right? Like we can often, most of the time, control the seizures, and we can regain those lost skills or plateau if that's what's going on at that time.
Yeah.
All right. The follow-up question here is meds before seizures, and are meds, like if we know 90% of kids with deletions are going to develop seizures or are likely to develop seizures, why not start meds preemptively? Or the converse of that is, are meds necessary for a first-time seizure, or could you continue to manage? Or are there other managements?
Yeah. And these are good questions. So we typically don't do medicines before a first seizure. The kind of the basic thinking is that if seizures are going to start, they're going to start. And, you know, even if you're on a medicine, they're probably going to start anyway, because, you know, once they start, we start a medicine, we go up to a certain dose, we try to get it controlled. Sometimes that first one's great. Sometimes you have to add a second one, but you're not going to know that perfect combination beforehand. You're not going to be able to start like 2 medicines, get up to high doses and know that you're going to prevent things from coming. So it's one of the things where if they're going to happen, they're going to happen. But, you know, one of the keys is just to be aware of what to look for, to catch them early and to bring them to the doctor's attention. And so if there is, if it's a single seizure, the other type of seizures that we see sometimes, and these a little bit more often, these can be the first seizure in kids that don't have deletions. Occasionally some deletion is called a focal seizure. So it's a seizure that just comes from one part of the brain. They can last, you know, anywhere from like 20, 30, 40 seconds or maybe longer. You might see moving of like one arm or stiffening of one arm. The head or eyes might go to one side with some staring. And so kids that have those, they can sometimes have a seizure like that, and then their EEG will just be normal in between, and then they might have another one for months. So depending on the type of seizure, if it's just a single seizure like that, or if it's even if it's like a little bit bigger one in the setting of a fever, we may not start medicines right away. We probably check an EEG, and if it looks okay, you know, sometimes we'll just watch and see what happens. If it's, you know, drops or myoclonic or absence, and there's multiple seizures, then we typically start medicines, because like once those start and you start to see, you know, multiple events, then that's probably just going to keep continuing without intervention. The one thing that we do sometimes before seizures start, you know, we were actually going to do a study, but people just started doing it on their own so much it was hard to actually get a study done. But you know, we'll sometimes have kids start a low glycemic diet ahead of time, and the reason we kind of are more okay doing that, other than as opposed to doing medicines, is that first of all, there's no medicine side effects, but what you know, what we've seen, and I don't think there's any like data out there, but just from what we've seen, and I don't know how many kids, 100 kids, you know, kids that are on that, you know, a low carb, higher fat and protein diet, they tend to just do better developmentally. They just have better focus. You don't have those big sugar rushes and the crashes. So, you know, there are other benefits. Plus, it's just healthy. It's a lot healthier than what I eat. That's for sure. So, I mean, it's, you know, and for the kids that haven't had seizures yet, we don't count carbs specifically. So it's not like a hardcore diet, but it's, you know, just keeping to fats, proteins, and you know, carbohydrates that don't raise your blood sugar that much. And it's a healthy way to eat. And we do, like I said, we see benefits such as better focus and attention. So that's one thing that and even that's not going to guarantee that seizures aren't going to come. You know, it's kind of like with the medicines, if they're going to happen, they're going to happen. But, you know, the hope is that they might, when they happen, they might be milder, they might happen later. We don't know specifically, but then if the seizures do come, what we do is we tighten the diet up so that we do have a strict carb count, and it's a lot easier to do if you're already eating the same foods, but just not strictly, versus if you're eating kind of what I eat, then you have to switch all the way over to these healthy foods, and then and that's just a bigger kind of shock to the system if seizures start. So it's easier to switch to a more strict diet if you're kind of even more loosely doing it ahead of time.
That's a really nice thing that parents can do. I mean, with the guidance of nutritionist or their neurologist, and all the Angelman clinics should be able to counsel on what a low glycemic diet looks like in Angelman syndrome.
Hey, Liz, I have to point out that tomorrow is 12:15 Eastern is the diet talk. So
make sure to tune in for that. Now, that's a really helpful adjunctive treatment. So last question before we get into the questions that are coming in hot to the Q&A box.
Wow.
Oftentimes when parents get that first EEG, they'll hear, well, there was no seizure detected, but it wasn't normal. We get this question all the time. What does that mean? Is there a characteristic Angelman EEG, and what does that kind of look like?
Yeah, it's almost like I often call it like a normal Angelman EEG. There's so the things that we look for when we're looking for risk of seizure, they're called spikes or sharp waves. They're just kind of what they sound like. They're these big pointy sharp looking things on the EEG. What we see there was a study a while ago, but it's like 95+%, and that sounds about right. It's closer to 100. There's a finding called we call notch delta activity. So it's delta activity is it's slow. It's less than like 4 bumps per second. And so we often see that in the back of the head on kids, EEGs for kids with Angelman. As they get a little bit older, sometimes it's a little bit more in their frontal area, but it's this kind of, there's these runs of, there's kind of taller, slower waves, and there can be some little sharpness kind of mixed in, but if you've seen enough of them, you can kind of tell what's, clearly a spike and a wave afterwards, and what's just a bunch of waves with a little bit of sharp pieces mixed in here and there. We'll get EEGs sometimes that say, frequent, occipital seizures, but they're not at all seizures. They're just these kind of typical Angelman changes. Kind of over, over the years, we've, we've seen them, in certain papers we've done and whatnot. Like we've noted that it's not really tied to seizures, but kind of the more delta that you have, kind of the less the better. Basically, the less these slow rhythms, the better. But just recently, a paper was published that now that there's a lot more fancy technology than we had back then. I can't believe I'm old enough that like I can talk about the days without the fancy technology, but they can actually quantify the amount of the delta, and so that's helpful clinically. We can just kind of look clinically and see that it's less, but what this is really helpful for is it's going to be a big thing for clinical trials and for things where we really have to like have a number, be able to quantify, like, is there less, is there more? We can just look at it and say, yeah, it looks like it's less, and that's helpful, and it really matches development. Like when we see kids' development take off, we get an EEG, we'll see less of it, but now we have the technology to actually quantify it, which is kind of a cool thing.
Super cool and really exciting as a potential use to measure whether therapeutics are helping or not. It's really super exciting work. All right, let's jump into questions here. All right. So we have some questions starting off about Epidiolex. How effective is Epidiolex in preventing seizures? How was it created? Does it have any side effects?
That's a good question. How does it? So that was actually one of our board questions for the epilepsy boards is like, how does it specifically help seizures? And the answer is we don't know exactly how it helps seizures. It does. For years, that's what we said about Keppra too. Now we actually know how Keppra works, but it's so it's actually made from marijuana, and there's 2 pieces of it. There's the cannabinoids and there's THC. The THC is the stuff that people want for fun and amusement, and so that part's taken out by the drug company that makes it, and so it's just the cannabinoids. They don't get you high. They don't give you the munchies, and but yeah, it was shown to be a very effective medicine in trials. I think it was somewhere around 40%, but which is kind of a common number, but it was 40% of kids with more kind of serious seizure type syndromes like Lennox-Gastaut-Gervais syndrome. So it had a pretty good success rate for some tough syndromes. And so just kind of what we've seen in Angelman syndrome, we've seen good response from it for a lot of kids. And there's no one medicine that works for everybody. We have our favorites that we use. Epidiolex is getting up there as one of our favorites, but they're a favorite because they work for more kids and they don't work for everybody. So it's finding that right medicine for each individual person. But it has as much of a chance to work as a lot of other medicines. And one of the nice things about side effects is we don't see a lot. It can cause fatigue. It does that more so if it's mixed with Onfi or clobazam, because it raises those levels, especially of the metabolite of the drug, and that can cause a lot of fatigue. But if you add the Epidiolex, you get fatigue. By lowering the clobazam dose, that can really help the fatigue. The other one isn't really related to the drug itself, but you can get some like diarrhea, loose stools, that's from the oil that it's in more so than the actual drug. And most people with Angelman syndrome, that's kind of a positive. Like we've had kids that we've run Epidiolex and it's given them looser stools, but then that's let us get them off Miralax and Senna. And so in some people it's worked as a seizure medicine / laxative, which has been kind of a nice twofer. We don't have too many kids with Angelman syndrome, kids / adults that have loose stool to begin with, so it's not as big of an issue. We do occasionally have some, so it's a little bit harder for them, but for most people, it's more, they tend to be more on the constipated end, so it can actually be a positive. But the fatigue is the other big one, and like I said, if it's with clobazam, usually you can fix the fatigue by dropping that dose of that.
Do you have issues getting Epidiolex covered by insurance for Angelman syndrome?
We did when it came out. It's a lot easier now.
Okay.
It's not 100%, but it's a lot better than when it was, whatever it was 2 years ago when it came out. It's usually after a year or two, it starts to kind of loosen up a little. So, but not 100%, but it's much better than it was when it came out. Okay.
And a follow-up question about Epidiolex. How does it compare as a seizure med to medications like Banzel and Divalproex?
I think it works as well as any what we call the broad spectrum medicine. So, with Angelman syndrome, it's a generalized epilepsy. So medicines there's medicines that are known to worsen generalized epilepsy. So Tegretol, Trileptal, like Abatrin, like those are all Dilantin. Those are all medicines to avoid. So Epidiolex is what we call it's a broad spectrum. It means it treats all sorts of seizures like drops and absence. And so it works. As far as I know, it works as well as those. The valproic acid, though, I'll amend since it came up. So valproic acid or Depakote, it definitely works for seizures in Angelman. It's effective. It helps with myoclonus too. When we did our seizure survey back in 06 to 08, when I first started, we saw tons of comments that said, like significant regression, stopped walking, which isn't really a known thing with Depakote, but, we just saw so many of these responses. It seemed like it maybe wasn't, you see one or two, you think, well, it's probably from some other reason. Maybe it was the seizures. So didn't think much of it. We just kept seeing those responses. And then we started the clinic and started seeing everybody. One of the things that we saw in that survey was that Depakote was by far the most frequently prescribed medicine. But as we started seeing people that were on it, we did see a lot of them had significant regression. A lot of people that started when they were 2 and they were stayed on it, they didn't regress because they never really had a chance to get where they were going. We've actually seen at least a few teenagers who never walked until we took them off Depakote as teenagers and they started walking. So it can be significant. It doesn't have that significant reaction for everybody. I think we found about 2/3 of people that were on it had the noticeable motor regression. So if you start it and it's helping the seizures and there's no side effects, you don't have to stop it. We usually say don't start it if you don't have to, but if you're on it and there's no significant problems, you don't have to come off it. It's just that people with Angelman seem to be more prone to that. And I think, maybe not we, but I think it's because that there's some mitochondrial involvement with Angelman syndrome. And we know that people with mitochondrial disorders, Depakote is just completely off the table for them. So I think with Angelman, it just affects the mitochondria mildly. So that's why you get these kind of mild symptoms, and it's going to affect it differently for some. So some people it probably isn't really affected at all, and they're going to do okay on the typical. But more people than not will have pretty noticeable side effects from it. So we try to be careful of that one.
One day we'll find time to do that study and get to the bottom of this mitochondrial question. We've been toying with this idea for years.
And it's been a theory for a while, but if we could prove it.
Yeah, it'd be really nice. All right. Shifting gears off of meds for a second. What is a motor stereotypy and how is it different from non-epileptic myoclonus?
Oh man, they're getting harder. It's like
your oral boards.
Or whatever, as you go on, it gets harder. So non-epileptic myoclonus is almost, think of it as more of an involuntary thing. So there's tremor. What we see in younger kids, and it continues throughout the lifespan. People with Angelman syndrome, they have tremors. So that's that, just kind of that like mild shaking. If you grab their hand, they stop. And it's usually what we call intention tremor. So it's when you go to do something, you notice it. The ataxia is the being off balance. That's why oftentimes when kids are younger, their feet are wide apart to kind of stabilize themselves. The myoclonus is just kind of a constant twitching. So like just really low level. When you see a myoclonic seizure, they're big jerks that could, almost knock someone off a chair. For non-epileptic myoclonus, it's usually just real mild. And if you look in their hands, that's where you see it most. Instead of like a kind of that tremory kind of shaking, it's more twitching, and it's just it can be very subtle sometimes. But if you hold their hands and you feel the twitching continue, that's more likely to be myoclonus. Most adults will have some in their hands on and off kind of all the time, and it doesn't really bother them. But in some adults that have non-epileptic myoclonus, it gets to the point where it almost looks like a myoclonic seizure. It's bigger twitching of the arms, and then if it gets bad enough, the face and the legs can be involved, and it can last for minutes, hours. So the myoclonus is twitching. Motor stereotypies are more, they're not quite tics, but they're like what we call like semi-voluntary. They're not involuntary, like the twitching that you can't stop. It's almost like you have this kind of this urge to kind of do the movements, and you kind of have to feel better. So it's, if you really focus hard, you can kind of stop and not do the stereotypies, but it's hard to tell a kid with Angelman syndrome, like, right, don't do that. Like they're just gonna, and so they're stereotype movements, but they're not, they're not tremulous, they're not twitchy like the myoclonus, they're more just movements. And it's one of those things where, if you look at enough people, you can kind of tell the difference, but it's for, people that don't have aren't neurologists, it can be tricky.
Well, this brings up that the study that we were mentioning earlier. So the ASF recently funded a study that's about to get started up, which is going to be kind of characterizing all these different movement disorders that we see within Angelman syndrome. And so this will be run by Rob Carson at Vanderbilt University, and there'll be more information out, I think, even this week about that study. So keep an eye out for that. All right. Question from a parent of a younger child. So for that parent who has a 15-month-old, 18-month-old who maybe hasn't started having seizures yet, if they're worried about it, do you have favorite resources for videos or information to read about seizures?
Well, that's a good question. I think the foundation has, I think, some stuff online, which is great. So for Angelman specific stuff, there's the Angelman Foundation website should have information just for seizures in general. Epilepsy Foundation of America website has some good information about just the types. If you on the Angelman website, you can kind of see about, like, learn about the different types, like I just talked about, the myoclonic, the atonic. And then if you went to a place like Epilepsy Foundation, they'll have, I think, they have descriptions and even videos of some of those types. So you kind of look for what types you're thinking about, and then you can go to the other website and look up those types, and really you should be able to see some examples of of head drops or tearing spells or whatever. There's somebody who's put them on the
yep, I think they're all popping up in the chat box, which is great. So the Epilepsy Foundation was what I was going to say. They have great videos on their website, and I think they're pretty accurate as to what those seizure types also look like in Angelman syndrome.
Yep.
This might be a good time to share also about the specific resources people can use, the one-pagers for seizures that are on the website.
Yeah, so the neurologists and the clinicians within the 15Q Clinical Research Network recognize that, again, this issue around first-time seizures and non-epileptic myoclonus or non-convulsive status epilepticus are two things that really drive a lot of anxiety within the community, and rightfully so. You're worried about your child having a seizure and showing up at an ER, and the physician there actually knowing what they should be doing and what's recommended by clinicians who know Angelman syndrome. So the neurologists within the 15Q Clinical Research Network put together a one-page seizure document. That's kind of a document that you can have, in your pocket on your phone, that you can hand to a provider in an emergency room, that kind of gives an overview of the recommended ways to treat first-time seizures in Angelman syndrome, or breakthrough seizures in Angelman syndrome. Likewise, this non-convulsive status document does a similar thing, and it walks through what non-convulsive status is, what it might look like. It even has pictures of what an EEG might look like for a child or an adult who's in non-convulsive status, and then gives an outpatient management guideline that I'll actually let you briefly discuss, Ron. It's your management guideline.
For the non-convulsive status, or
for the non-convulsive status.
So we did a kind of a retrospective look back at our clinic. I can't remember how many years ago, but looking at all the people that have had non-convulsive status and what we used to treat, what helped, and we found out that I think it was 80% of it was maybe more than that, but it was 80% or more of kids we were able to keep out of the hospital. What we do is we do a kind of a short-term kind of tapering schedule of Valium or diazepam. The other benzos also work, but for some reason the Valium just seems to work better. And I don't have a explanation for it. It's just I'm trying it in enough kids, that just seems to work better. But it's a kind of a bigger dose. We do it 3 times a day. We do that for a couple of days, and a little bit less. And often just, one like 6 or 8 day course really makes a big difference. And if it's not 100% gone, we do another one that usually works and keeps people out of the hospital. It seems like that's, there's also, you go up on whatever meds are, if they're on, Keppra, Clobazam, whatever. We usually increase their medicines to try to prevent it from happening again. But often what happens is there's something, either there's an illness or there was travel, which threw off like GI and sleep stuff, or there's some triggering event, and then sleep gets thrown off, and then kids just don't seem right, and then they're just not bouncing back the way they should, and that's because they're in the non-convulsive status. So we're usually able to treat it as an outpatient, but occasionally if it's not breaking as an outpatient, we have to admit. Luckily, over the years, we've only had to do that a few times, which is great. And when the benzos fail, we often use steroids, not the kind that Barry Bonds and those guys use, but the kind that you work for asthma, so prednisolone, and those work for most people that the benzos don't. Luckily, we haven't really had to go past those almost ever. So usually one or two works. For really bad cases, we've had to admit and do IV steroids and then a longer taper. But usually at that point, we've I don't think we've really, except for maybe one or two people ever in our clinic, we've had to go past that. But it's rare that either the benzos or the steroids or both don't help break it. But once it kind of kicks in and it's the status is there and it's not responding to usual type meds, you need something kind of more powerful but short term to really kind of pop out of it.
Have you ever used ketamine for that?
We haven't gotten that far, luckily. So,
good, great.
So, yeah,
perfect. This came up recently in the community.
If we had to, but luckily we haven't gotten that far. So,
okay.
All right. If like in the one case that I can think of, where and that was an unusual case where the usual stuff didn't work. We ended up doing a midazolam drip. So Versed said, they go to the ICU, they get intubated, and they do and that's kind of it's a benzo like Valium or Klonopin, but it's given in a continuous IV drip. But that was their unusual case of an international patient that came to us in status for many months, and so that was a tough one, but ended up breaking it. So that's I think that's another, it's not going to happen often, but even after 10 months, we were able to kind of break that one episode. So it's important. It's never too late, even if it's going on for a week, a couple of weeks, whatever. It's never too late to break it.
I think as a parent, that's the most reassuring thing to me, is that the typical tools usually work. And even if it's been going on for a long time, we can still usually rein things back in. Not usually, pretty much always.
Yeah. And in really difficult cases, we still have options.
Hey guys, it's Amanda here. As you know, we're here for you, our community. If you have questions about any topics we can discuss in our podcast, or if you have ideas for future episodes, we'd love to hear from you. All you need to do is email me at dearamanda@angelman.org. Thank you so much for listening and your continued support of the Angelman Syndrome Foundation. This might be a good place for Ron or you to talk about, as a newly diagnosed parent, would you advocate to work with your neuro to already have some sort of rescue med in place in case the seizure does come on? Can you talk a little bit about that, either one of you?
Sure. We usually don't do it routinely, but if families are worried and bring it up, sometimes we'll do that. We definitely don't do it for schools. Like when we're talking about like seizure plans, school meds, if they've never had a seizure, we don't really have a school plan. But if families would feel more comfortable having something at home, and usually for kids that age, the one option is the rectal Valium, it's called Diastat. There's no really kind of right or wrong answer. If you have a first seizure and it's a big shaking seizure that you would normally use a medicine like that for, you're going to call 911 anyway for the first one. So it can kind of go either way. Like I said, we usually don't do those medicines unless there's, just in general. But if a family's especially worried about it and they feel better with it, we'll sometimes just make sure they have Diastat just to be safe.
Oh, there's a relevant question in the Q&A box. How typical is it for an Angelman individual to have a seizure longer than 5 minutes and truly need the emergency diazepam?
That is a great question. It's unusual. It's pretty unusual, actually. So, it sounds weird because everybody has the emergency medicine, but it just doesn't get used that much. So what does get used more often is, and this we definitely wouldn't do until seizures come up, but we'll give families either usually oral Valium, but it can be additive, it can be something else. But basically, if you're having, if you have drop seizures or absent seizures, then you start to have like more than you normally do that day. It's kind of ramping up a little bit. Instead of giving something rectally that's just going to knock them out, we give a smaller dose by mouth, and that can kind of quiet a seizure cluster. But that we do kind of case by case, like if that situation pops up, we do it and we have it on hand. But as far as a long seizure that's going to go 5 minutes, it's pretty unusual. If it is going to happen, it's almost always going to be with a fever. Okay. It'd be unusual, ephemeral, but it's not unusual. Even if you've never had a seizure, or if you've just had a few, if you get influenza and you got 104 temp, it's possible.
Yeah.
Yeah. Kids without Angelman, just typically developing kids, a certain percentage are going to get seizures with big fevers that can last many minutes with just totally typical development. So it's one of those things, little kids in fever, seizures is on the table.
Yeah. All right. A good question about Keppra dosing. So if a child is at their maxed weight-based dosing, but their blood levels are showing that the level is lower than expected, would you continue to go up on the dose, or do you stop at the weight-based dosing?
Yeah, it's a good question. So everyone's weight-based dose is probably a little bit different. So I can't remember what the FDA dose is. It might be something as crazy as 40 mg per kilo, but we use up to 100. Sometimes you go a little bit higher. So that's the and And that's also more of a difference between like having an epileptologist versus a general neurologist treating you. Like as an epilepsy specialist, we all use higher doses than non-epilepsy specialists. It's just that, when you do nothing but treat seizures all day, you just get used to the meds. So we use higher doses. So for Keppra, we pretty routinely go up to 100 mg per kilo per day. Sometimes a little bit higher. And then in adults, we'll go to like 2,000, 3,000. But knowing that, the going back to the actual question, the answer would be yes. Levels don't help that much like specific levels for Keppra don't really give you a good sense of how well it's working. The better thing that those levels are used for are compare like one to the next. If it's like a level of 40, you go up levels 41. With increasing doses, you're not really getting much of an effect in the blood. So at that point, you might want to stop. But if the increases are driving the level up, then it's and it's being well tolerated, there's room to keep going up. Yeah. Keppra is one of those medicines that's it's really safe. You're not going to have any terrible side effects by going too high, but at some point you get to a certain level where going up on the dosage isn't really going to change your level much, and then as you get higher and higher, you get more risk of like the sedation or behavioral type side effects. But if you're not seeing the result in the seizures, then it's not worth it. But yeah, most people's minimums are probably not as high as our minimum or other epilepsy people.
So perhaps first revisiting whether we're truly at the highest weight-based dose.
Yeah, but by weight, we pretty routinely go to 100 per kilo per day. Okay. So for a 10 kilo kid, 1,000 per day. I did the math right. Yeah, 10 kilos, 1,000 milligrams.
Okay. All right. Good advice. Have you ever seen a patient with Angelman syndrome not respond to Diastat for a breakthrough seizure?
Yes. So again, not every medicine works great for everybody. So, Diastat is, it's rectal Valium. One thing that we have now that just came out is nasal Valium. So you have to be a certain size. So for little kids, it's not really an option, but for like older kids and teens, for sure. We can do it nasally now instead of rectally, which is just more humane for everybody. It's just better. And so, if for some reason it doesn't work, if there's room to go up on the dose by, if it's tolerable, you can sometimes go up on it. But if that doesn't work, then there's Ativan, which is lorazepam that comes in little drops that you can kind of drop into the mouth. Or there's clonazepam. Clonazepam is slower acting though, so it's not ideal to stop a seizure. But definitely the lorazepam would be an option. There's also nasal midazolam, nasal Versed. It's called Nasalam. It's only been out for months. It's been out less than a year. So there's now, before it was just that you had Diastat and that was it. But now there's a couple of different formulations of the Valium, but there's also the lorazepam or Ativan, which you can try, or the Nasalam. It's, in general, people with Angelman syndrome respond really well to that whole class of medicines, but not everyone does well with every one of them. So it's finding everyone's right drug. For most people, it's going to be Valium, but it's not for everybody.
Same question as the Epidiolex. Have you had issues with insurance coverage or school pushback about using the intranasals versus the rectals?
For schools, no. When Nasalam wasn't FDA approved and it was just nasal Versed that like a specialty pharmacy would make, then yes, like schools wouldn't take it. The inpatient floors up sometimes wouldn't take it. So, but now that they're both FDA approved, schools have to accept it. And I don't know if it's just us or if it's just Massachusetts, but we seem to have good luck with the nasal Valium, but the nasal Versed has been harder. I don't know if it's because you went from rectal Valium to nasal Valium, so it's just the same drug but different route. But we've had a lot more luck with the nasal Valium versus the nasal Versed for whatever reason.
Interesting. Okay.
Yeah, insurance never makes sense.
That is true. That is the one truth. All right, let's talk about seizures and puberty. Any general approach to treating breakthrough seizures that occur before or during periods?
Yeah, that's a great one. The nice thing is that with the onset of puberty, in general, we often see seizures kind of get better for most people. And no, that's kind of in general with puberty. I guess puberty comes, things get better. But for girls, when they first start their periods, that's a different ball game, because and this is kind of a strange fact, but estrogen actually is what we call pro-epileptic. So just having estrogen worsens seizures. Having progesterone is anti-epileptic. So having progesterone improves seizures. So when everything is working in sync and it's all nice and smooth, the two balance out. And so the difference between girls and boys is really non-existent. The two just balance out and it's all good. When 11, 12, 13-year-old girl starts having periods, it's never balanced. And so that's when you get into trouble. There's during the middle of the cycle, when there's ovulation, the estrogen can get a little bit high. And then the big thing is during the periods, the progesterone just drops. That's what causes the bleeding. And then so like those couple PMS days right before the period, some girls can be at a higher risk of seizures. So sometimes it depends if it's just kind of here and there. Sometimes we'll just do Valium during the period. Like we'll wait for the first PMS day to come and we'll do like one of those little Valium tapers during the period. If it's an issue, and it's an issue every cycle, we'll often have people see either the adolescent specialist or gynecologist, and you go on birth control pills, and that by taking estrogen and progesterone, it just tells your body like what levels you need to have, and it just puts the levels there, and then you don't have to worry about these huge swings that the early teenage girls will have. So.
Did you know that you were going to also be an endocrinologist when you became an endocrinologist?
No, I never thought I would talk about periods as much as I have over the last 10, 15 years, but here we are. Yeah. But it's really hard. Like, once in theory you reach full maturity, as a woman, and it's not for everybody, but for most people, everything balances out nicely. For 12-year-old girls, it's never balanced, and it can be bumpy. For sure.
Absolutely.
But if it's just here and there, if it's just a few at the beginning, just the Valium during the cycle can be really helpful. And if it's kind of a constant problem, especially if there's seizures with the periods, plus the periods are either irregular or extra heavy, or definitely if they're painful, then just, and you can even do continuous birth control pills and just stop them from happening at all, which is a nice option for a lot of people.
Just add it to the daily med.
Just add to the daily med and just stop them.
Yeah.
Yep.
Okay.
Good.
Great advice. Let's go back to preschool age. All right. We're going all over the place here, but this is a scenario that I think probably every family resonates with, but I think it's a good scenario to run by you here. So a 3-year-old, this questioner asked, my daughter's almost 3 years old with UB3A mutation. She sometimes, maybe once a month, has what appear to be drop seizures, or what they've thought might be drop seizures. I've not been able to capture them on video because I could never see them coming. She's usually scooting around on her bottom, then stops, falls back, and usually hits her head. The local neurologist said it seems more like GERD. Does that make sense? Or she hasn't been able to capture them on video just yet? And she had this common scenario of having an EEG that did not show seizure activity, but was normal for Angelman syndrome.
Yep. That's a great question. So that's kind of goes back to the, I know we talked about like seizures versus myoclonus, like how to differentiate. One thing that we didn't mention, there are GI symptoms that can mimic seizures. Just kind of arching back like that. It's tough. It is hard to know without video. So sometimes if we don't know something's a seizure, but we really suspect it, we can start seizure medicines and see if they stop. But on the other hand, if there's if it's potentially a GI thing, we'll often treat that. So we just put someone on like a reflex medicine, and if they stop, that's our answer. But kids, especially young kids, when they reflux, and like pretty much all babies do, and a lot of younger kids do, with or without Angelman syndrome. But with Angelman syndrome, it's a lot more likely because kind of that low tone you see in the arms and legs, you see it in the GI tract too. So it's easier for stuff to kind of come up. So when they get reflux and it actually causes discomfort, kids will just kind of as a reflex just arch their backs, kind of almost trying to make their esophagus longer so it's not so painful. And so we get a lot of, a lot of times we'll see, events that are like even sometimes like question infantile spasms. And then we look at the video, we see the arching, and you can tell it's just, it's discomfort. Like kids will arch, they'll kind of writhe around a little bit. So ideally seeing on video would help. But if it's, if they're kind of consistently happening, here and there, and the question is it reflex? A lot of times what we'll do is we'll just treat it as reflex. And if they stop, then that's our answer. But definitely, kids with Angelman syndrome, everyone with Angelman syndrome are super prone to GI issues. The biggest being constipation, reflux. So sometimes reflux or upper GI symptoms can look like seizures, either kind of arching backwards or those kind of things. And then sometimes poor sleep can be GI symptoms. It can be constipation, reflux, or both. We'll have kids waking up at night crying. I know this isn't the sleep talk yet, but if, typical bad sleep in Angelman, kids wake up and they're just happy and want to just start the day and ready to go. And then, that's just typical Angelman sleep, or they'll whine until they see a parent and then smile and then they're ready to go. If they wake up crying and you go get them and they're still crying, it's discomfort. And majority of the time it's GI. It could be something else like an ear infection, whatever, but it's GI till proven otherwise, really, because there's just such a high rate of reflux and constipation. Sometimes you don't get that until they're in bed laying down, and then they don't have gravity helping them out. Everything just kind of comes up and they wake up crying. So it's always, whether it's question seizure, question sleep, question, like GI is always in the conversation for those.
So treat the GI. If there's any possibility of GI, treat the GI first. See if it can get better.
Exactly. And if the event stopped, then you got it. If you're on a bunch of GI meds, they're still happening, then it's more suspicious.
And parents can feel comfortable that if it was happening as infrequently as one of these questionable drops a month, we're not causing permanent long-term damage by allowing that to happen.
Yep, exactly.
All right. What about, can kids grow out of seizures? If someone has been on meds for 6 or 7 years and not had seizures, what's your general thinking about peeling back medications or stopping medications?
Yeah, that's a great question. So we looked back at all our adults, I forget how many years, like a few years ago. And what we found was about 2/3 of people, kids with Angelman syndrome that had seizures, when they got to, puberty and adulthood, about 2/3 just kind of stopped having them. And then out of that other third, I think more than half were pretty mild. It was either kind of monthly or a few times a year, but then there was still that kind of small subset where it just stayed hard into adulthood. So luckily it's, the percentage of seizures, kids to adults, is much higher. Hard seizures is much higher, but as an adult, even though the odds are small, there's still a smaller group that still has them, and then an even smaller group that still has hard ones. So it's not everybody, but that tends to get better. So there's a couple of things. One is, what's the subtype if they have a mutation, UPD, imprinting center, that they are more likely to outgrow their seizures. So it's a little bit easier to take off medicines. For kids with deletions, they can still outgrow them. The big thing with coming off seizure meds, though, is that even if you feel pretty good that the seizures have been quiet for a while, a lot of the meds we use do more than one thing. So, seizures can kind of go away and then be replaced with this kind of non-epileptic myoclonus. So the kind of the meds that work best for that are ones that also treat seizures. So Keppra, Onfi, Epidiolex, those kind of medicines can really be good for the movement disorder piece in adulthood. So sometimes the seizures will stop, then they'll move into those. Some medicines like Lamictal can be a mood stabilizer. So if they're on that, sometimes that'll continue. So but if someone's on a couple different medicines for seizures, and one of them we know can also help with myoclonus, the other one not so much, then we will probably come off of that one. And then as far as coming off the final medicine, it's just a question of is it helping something else? And if it is, we usually leave it on, and that way you get it's treating something, but then you also have that kind of peace of mind knowing that there's a seizure medicine still there. But if it's doing nothing but treating seizures, as far as then sometimes we'll come off it. Sometimes we'll come off a med and the seizures won't come back, but then the sleep's bad and the anxiety ramps up, and it's like, oh, you should probably put that back. And we put it back for those reasons. Onfi is one that we know helps with sleep and it can help with anxiety. So we've had a few people that they've gotten to adulthood, they haven't had seizures for a while. We've kind of slowly tapered them off, and then next thing you know, they were just super anxious, and we just had to add it back. So we try to start with meds that can treat a couple of things, and if they are treating more than one thing, then sometimes even if we think the seizures are gone, we leave them on for other purposes. But if it's a medicine that's really just treating seizures, and it's been a few years, it could be worth coming off. And then if it turns out, and if it's a medicine that's maybe having some side effects and it's treating sleep, and you come off and the side effects are gone and sleep's not as good, then you don't want to put those side effects back. So you just find something else for the sleep.
I know, different.
So it's just a lot of trial and error kind of, but.
Okay. And related, you've kind of addressed this, but is there ever a point when you feel like a patient with Angelman syndrome who hasn't had a seizure is kind of off the hook? They're not going to develop seizures.
Yeah, that's a good question. The longer you go, the better you can feel. So, most kids with deletions are going to start in the 2 to 3 range. Some will be a little bit earlier, some might be a little bit later. But once you get towards 5, 6, 7, if nothing's happened, it's not a 0% chance, but the odds are really going down. And at that point, if you haven't had seizures by that age, even if you are going to get them, they're probably going to be pretty easy to treat. And then with the non-deletion subtypes, certainly that same age range, but sometimes they'll start a little later just because it's a little milder type. So they might start like 5, 6, or 7. But if you start getting towards 8, 9, 10 with those kids, then the odds are really going down at that point. And just the older you get, it's never 0, but the older you get, the chance just goes down, down, down. Once you get into, if you really hit puberty and you haven't had any, odds are really low at that point.
Any rationale to patients or individuals who might stop having seizures for 10 years and then all of a sudden start having seizures again, like in their 20s?
That's a good question. It doesn't happen that often, but when it does, there's usually something going on. So first thing you always have to ask are they seizures? Is it non-epileptic myoclonus that looks like seizures? Because they're easily mistaken for one another. If they're true seizures, then if it's a woman, you always have to think hormones first. Like, are there problems with the cycles? And if the question is, well, yeah, they have been happening like every, like 17 days, and then that's your answer. And if it's not that, then it could be random. But if they just come back after years, there's usually some sort of trigger. So if it's not hormones, then think about GI, think about sleep, think about anxiety. Are any of those really kind of going up, off the charts? And a lot of times, like fixing that trigger can really help, kind of quiet the seizures back down. But if there's years and years without, and then they pop back up, there's usually a trigger, and it's you definitely treat them. But in question 1, are they seizures or is it some sort of movement disorder? But then question 2 is like, what's different? There's probably something that's kind of triggering them that's fixable.
Right. I don't want to keep you all night, but can we keep you for another 10 minutes?
Yeah, I'm good. Okay, I don't have any big plans, shockingly.
No, not at 9.
No, that was my girls.
Okay, good. I got a lot of good questions here still. All right. We talk a lot about developmental regression or plateaus with seizures, but what about the converse of, can multiple medications lead to developmental plateaus or even developmental regression? So a child who might be on Keppra, Amphi, Epidiolex, all these medications, particularly at a young age, should we be worried about that inhibiting developmental progression?
Yeah, no, that's a good point. So it's one of those things that's kind of tricky to like really kind of grasp. So when kids are seizing and you start these medicines, if they're working for the seizures, they help the development. But then once seizures have quieted, now all of a sudden you don't have all these seizures that are going on that you're treating, and so you've got a brain that's not seizing, but then all these medicines, and then they kind of become, they can become more of a hindrance than they're worth, and then you start taking them away. So they do better when you start them, and they do better when you stop them, which is weird, but that's kind of how it works. A brain that's seizing needs them and does better with them. A brain that stops seizing, that still has them, they can kind of get in the way. So I mean, they can, like, if the side effects are bad enough early on, you can kind of get that. But usually you'll know, even if your seizures are getting less, if there's clear side effects as you go up, But for the kids that, you start the medicines and then they're just they're just better. The seizures are better, so everything's better, and they kind of cruise for a while. It's at that point where it's, you have to kind of think about it, and you're like, it's like, well, all right, no seizures for a while. Like, should we start to take some of these meds off? Like, development's better, but is it as good as it can be? So, we're always kind of on the way up thinking, okay, are you seeing any seizures? Is there any, anything that we're missing, anything that needs to be treated, and kind of think, do we need to go up and up? And then once things are good, kind of every visit, it's like, okay, can we get rid of anything? So you're always wanting to, kind of look at like, do we need more of something? Is everything kind of where we want it? And then once things are really good and you're cruising, then it's like, okay, can we pull anything away? Because, you might find that you start like 1, 2, 3 medicines, and then you see an improvement for sure because the seizures are better. But yeah, you don't know what the side effects of the medicines are. You see that improvement at first. If you start medicines and things get worse, then that's a red flag. It's just a bad medicine. Try something else. But if things do get better and then they're just better, but kind of there, and you're not seeing that progress like you want, we'll often check an EEG. And if if there's no clinical seizure activity, the EEG looks pretty good, then we always have to question, is it the meds? Like, are they now over medicated now that the seizures are better? And what can we get rid of? So that's, if there's developmental stuff and there's still active seizures, it's probably that. But if the seizures are really quieted and you're either seeing regression or more likely just a plateau, just things aren't going forward like you want with the seizures better, is there a medicine that's kind of dragging you down?
Yeah. On this topic of multiple medications, I realize I've been neglecting the chat box for the Q&A box. So I have a question here in the chat box. My 15-year-old twins with Angelman syndrome are on Omphie, Keppra, Vimpat, Epidiolex, Valium, and have a VNS. They're still having 2 to 3 hour seizures at least 3 times a week, lots of times with heart rates over 200 and low oxygen, and having to be transported to the hospital. Any recommendations as to what we could do to help change the seizure activity?
Yeah, I guess the big question there would be is, have the seizures been captured on EEG? So when you think teenager, 2 to 3 hour seizure, lots of meds that aren't working, it sounds a lot more like non-epileptic myoclonus. Non-epileptic myoclonus can last for hours. And it even though it's not a seizure, just by your body twitching that much for so long, it will get your heart rate up, and it'll cause fatigue, because it's almost like going to the gym and you're just like working out for hours, and then you can just get really kind of worn out.
Sounds like they have been captured on EEG. We're getting
definitely seizures.
Yeah.
Yeah. I guess the question is, did they read the EEG right? Yeah, that would be unusual to seize for that long as a teenager. Whereas the myoclonus, we can see it go for hours, and it's and it depends, just because the EEG of Angelman can look seizure at baseline,
right?
But at that age, I really haven't seen anyone seize for that long. But some of these cases of myoclonus can be super refractory to medicines, and in that case, when so many things fail, for the myoclonus, the big thing is like, what's the trigger? So is it, especially for 15-year-old girls, is it hormones? That could be a huge thing right there, just fixing the hormones. And then we look at sleep, we look at GI. There's usually, when it's that hard to control, there's usually triggers. But if they are, it depends on what kind of, the only seizures that can go for hours are either tonic-clonic, which is just true status. And in that case, you're generally in a hospital, or absence. You can have that, but that's really a non-convulsive status, which is really unusual in teenagers. For that specific situation, I'd really question whether the EEG was read properly. For a teenager with Angelman to have seizures like that, it would be super unusual, especially on all those medicines. But with myoclonus, it's pretty standard. Like, we have some people that nothing works, and we just try this and this and this, and they're for some people, they're really tough to treat. But we just keep trying new stuff.
Yeah. So in these settings where we have really, really, really challenging to control seizures, and a local neurologist might be, completely at the end of their options, this is something that we do not infrequently is have the local neurologist connect with either you. I'm now committing you to think without your permission, but
the group is in general. Yeah.
Yeah, exactly. And because you could have an Angelman epileptologist take a look at the EEG and make sure that there's consensus that what we're calling seizure is actually seizure and not just abnormal Angelman EEG.
Yeah. The other thing to think about too is, if it doesn't seem like a true kind of Angelman type seizure, and we've had this before, if the seizures don't really fit with what we're used to with Angelman, and there's just either it's a different type or different pattern or just something that's super unusual. The question is, do they have Angelman plus something else? Which sounds crazy, but we've had a handful of people that have had Angelman plus like a metabolic disorder. Like I think one had tyrosinemia. There's Angelman plus like a CDKL5 or an, but you can have a Angelman plus a second genetic syndrome. So in those cases where, if there really is something going on that's very unusual for Angelman syndrome, and, the EEG isn't quite the same, the pattern's not the same, it's not that you don't have the Angelman syndrome, but do you have something else? That's when going back to it. And especially for teenagers and adults, who got the diagnosis, they probably got the diagnosis at Angelman, that's what you got. So like it wasn't part of a whole exome or something fancier. So there could be a second, second genetic thing going on. But out of like the 350 or whatever people we've seen, there's been like 3, but still there's, 1 out of 100 has something else, and it can really throw you off.
Sure, absolutely.
Angelman only.
Yeah, I think the latest number that I heard was up to like 5% of children with one diagnosis may actually have 2 dual diagnoses by the latest whole genome studies.
Yeah. That's just our clinic, but I would surprise me if it was more like 5%. Yeah. So if it's something that doesn't really fit Angelman, that story really fits non-epileptic myoclonus perfectly. Long seizures, medicine refractory, in a teenager, that's we see that all the time. But if they are true seizures, then it could be Angelman syndrome usually doesn't do that. So it sounds like it's more myoclonus, but if it's really seizure, that's the next thing is there another syndrome? And by finding that second syndrome, that's what's going on. There might be medicines that are better for it or that are contraindicated for it, like the ones that they mentioned are all good for Angelman, but maybe they're bad for something else that might be going on.
Great. All right. Another chat box. Help. I didn't see the answer to the question regarding a relationship between tremor or non-epileptic myoclonus and anemia. We hadn't gotten to that question yet. So have you seen a connection between NEM and anemia?
It's a good question. I mean, not specifically, but like anything, we talked about GI and bad sleep, but really any kind of medical problem can worsen neurological issues. So if it's significant enough anemia, that can definitely, that's one of those things. Or it can be some sort of endocrine thing, like if it's a thyroid issue. But anything that's kind of off, the brain is really sensitive to that. So anything like hematologic, endocrinologic, just any other specialty that's not ours, they can, if something's off, you can see more seizures, you can see worse sleep, you can see worse movement disorder. So your neurological issues can worsen depending on just kind of overall health. And so, but something like anemia can definitely worsen neurological symptoms. And if it's iron deficiency anemia, which is common, we know that low iron, especially if you check the ferritin, it's really low, that can really worsen sleep. And then bad sleep is what really throws off. So it's almost like an indirect correlation. But if it's iron deficiency anemia, just that low iron can really make sleep worse. And then bad sleep, worsens everything.
Yeah, we talked about that earlier in the week. All right. Todd's paralysis. How common is that after a seizure in Angelman syndrome?
Good question. It's not super common. I think when we did our survey and even look back, yes, so it's what we call focal seizures. So that's the ones that we're talking about that kind of start in one part of the brain and stay there, as opposed to the other ones that are. I know it's confusing because we say it's a generalized epilepsy, but yet you can have focal seizures. But the epilepsy itself is still generalized. So even if they're focal seizures, you don't want to use focal seizure medicine like Thibert, Trileptal. But if you have a seizure and it comes from one part of the brain and it's kind of over the motor area, you can sometimes tire that part of the brain out, and then the other side of the body becomes weak for minutes or sometimes hours. But it's one of those things that you can just see sometimes with focal seizures, depending on where it is from the brain. So we don't see a lot in Angelman, but it doesn't mean that you can't have it. We definitely have some kids that have had Todd's paralysis, and it's like if you're going to have seizures with Angelman syndrome, the focal seizures are probably the easiest to treat. But they can be scary when they cause that paralysis. But even though they use the word paralysis, it's a temporary thing from just kind of the brain tiring out from the seizure, but then it comes back. But it's the reason some seizures have it and some don't. It's just kind of where they are in the brain, and if they're right over the movement area, sometimes you can have that weakness afterwards.
Cool. Thanks for that.
Yep.
Epilepsy.
Yeah. So it's not a common thing, but you can absolutely see it if there's focal seizures. It's just and we'll see it more in the non-deletion types because the deletions tend to have more of the drops in myoclonus, whereas the focal seizures we can see more in the milder types.
Right. All right. I'm going to tackle two more questions and then I'm going to let you go. All right. There was a post on Facebook asking if seizure meds can cause osteoporosis. There's also been some concern about chronic use of seizure meds causing weakening tooth enamel. Are there conditions that children with Angelman syndrome or adults with Angelman syndrome are at risk for because of their chronic AED use?
It's a good question. So, so it depends on the AED with the newer ones. So with, the kind of Keppers-Onfis, Epidiolex, Banzel, we don't see a lot of that, which is great. For the current adults that were probably on Depakote, that's a little more of an issue. And definitely medicines, there's a few medicines that aren't good for people with Angelman that are more famous for that. So like phenobarbital, tegretol can be really bad for bones. We don't see it as much with the non-Depakote medicines, but it's more of a combination of the medicine plus just decreased weight bearing. And even if kids or adults, with Angelman are mobile, they get up and walk around. They often have spent less time on their feet than typical people, typically developing people their age. So combination of some of those medicines plus just a lack of weight bearing can be a tough combo, and you can have decreased bone density. So it's really good to make sure to check vitamin D levels, especially if you live up here in New England like I do and never see the sun, and especially if you have someone that's like not a dairy person, it's real important to make sure vitamin D is good, and just making sure that you get enough calcium / vitamin D supplement, and definitely ask Heidi about that tomorrow. But get the vitamin D and calcium. Just make sure you stay on that, and just the more time on your feet, the better. But as far as the newer medications, we really don't see that. With Depakote, you can see that sometimes. And the medicines that are the big offenders are the ones that really don't mesh with Angelman, like phenobarb and tegretol. But sometimes the role of the seizure medicine, I think, gets a little bit skewed. It's really more the lack of weight bearing as opposed to the medicine. But some of the older medicines can play a part in that. So the best thing is prevention. Calcium, vitamin D, up on your feet, and just try to keep the bones healthy.
Yeah, absolutely. Okay. And our last question of the night, and we will try our best to get some of these other questions answered and back out to folks. I promise. But this comes from a family in Ireland who's feeling frustrated that their local neurologist is not interested in treating non-epileptic myoclonus. Are there good resources, publications about treatment of non-epileptic myoclonus? I should know this. I think you published a paper.
Yeah, that's not to say it's the best, but the only one I know of is the one that we published. But there's the I think it's just called myoclonus and Angelman syndrome. And we kind of talk about the the difference between the seizures and the non-epileptic, but yeah, that paper is always helpful. It might help them kind of get on the right page. And the thing with the non-epileptic myoclonus is that, like, some people look at it and say, well, it's not seizure, why do we treat it? But it's a huge quality of life thing. If you just kind of shake for hours, it's exhausting, it's scary, it cranks up anxiety. Whatever you want to do during that time, you can't really do. It's tiring. So and if people are upright when it kind of kicks in, they can fall. So it's it's not really, it's not dangerous for the brain, but it's a huge quality of life thing. So we treat it kind of as needed. If it's just a little bit in the hands and it doesn't bother anybody, just leave it alone. If it's enough that it's really affecting day-to-day life, then we treat it.
Can I ask one more question?
Yeah.
So this is more of like to put to the ease of mind of some families. One of the questions that I saw, but it's one of the ones that I think a lot of families struggle with, like, how is it okay to put your child to sleep after they have a seizure? The fear of our children seizing in bed is very real for this community, and I know it is for me. So if your child has just had a seizure, let's say it's 7:00, just had a seizure, you've given the seizure meds. I mean, can you give some thoughts or some help with that on what families should, how to give some peace of mind here?
Yeah, that's a very good question. So, so after a seizure, especially if it's a bigger seizure, the kids are they're gonna sleep, even if you don't want them to. The seizures are tiring. It's what we call, post-ictal, so after the seizure, and kids are, even if it's the middle of the day, if it's a big enough seizure, they're just gonna pass out. So, so as far as sleeping after the seizure, it's not only is it okay, it's almost going to be inevitable for a lot of kids. The nice thing is that seizures typically don't arise out of sleep for kids with Angelman syndrome. When kids do have seizures in the middle of the night, and it's not super common, but it can happen, it's usually because they wake up and then they're awake and they have one. So a seizure is not going to pop them up out of a deep sleep. I don't know if that's more comforting or not, but it's having them in the middle of the night is unusual, and usually if you do like an alarm or a camera or something, all it does is really kind of decrease parental sleep, and it doesn't do much else because you're just staring at it all night. But if you're extra nervous about it, sometimes you can use like a baby monitor, because if they wake up and they have a seizure, whether it's something that's convulsive, you should hear that. If it's a partial seizure, there's usually a noise, like a vocalization. So, and typically it'll happen after they wake up. So you might even hear them wake up, and then, they're awake. But yeah, it is, I know it's scary for a lot of people, but, seizures in sleep aren't very common. Like I said, if they do happen middle of the night, it's because they woke up and had one typically. And if they have a small one, they're usually like super self-limited. And if it is a big one, like a big tonic-clonic or something, it's most likely going to wake you up. Those seizures are pretty loud. So any kind of big one that would be more worrisome, if you wake up and have a little, head drop or two, it's not, there's really not much that's going to happen. But if they wake up and have a larger seizure, you're probably going to hear it. It's not, super, but it's one of those things where, you can't be staring at your kids 24 hours a day. Even though I know you want to, it's just, it's not possible. So, but I think just knowing that if they're in a nice deep sleep, they're not going to have a seizure. Like I said, if they do, it's going to be because they woke up, and most likely you would hear that anyway, because they'd be awake. If they have a bigger seizure, they're going to make noise. So you should, it should alert you if it happens.
Well, and I know I won't ask any more questions, but I will say that, I've had the pleasure to be able to work with you with controlling Jackson's seizures. And the one thing that really surprised me just as a new mommy here is that there are some side effects to the medications that can cause some issues, and it's all about kind of working with your neurologist to find the happy mix. For us, Jackson wasn't eating for how long, Dr. Thibert? Like, he just didn't gain a pound for like 2 years because he just did not want to eat. And we couldn't figure out what was going on. And when we finally got to Dr. Thibert and started talking to him about it, he said, one of your seizure medications causes a loss of appetite. And literally we tapered off that medication. And within like a week or two, he was eating like a horse and gained so much, like gained weight. So it's so interesting, and it's really important to be able to work with your neuro and to be able to work with these AS clinicians and these clinics that that have all this knowledge and this understanding, because I think that the seizures are the scariest thing that you can, I think our kids and our families, when they think of seizures, I think Liz said it best in the beginning, you think of these seizures you see on TV where, it seems terrifying. So I think working with your clinicians, if you want to get to an AS clinic, Liz, what should they do? They want to see Ron, they want to see Dr. Dewis, Dr. LBK, all the amazing clinicians in our network. What should they do?
Well, you can find contact information for any of the clinics on our website. There's emails, phone number, contact information for clinic coordinators. And we are certainly happy to help if insurance or Medicaid is providing difficulties with coverage getting to clinics. That is what the Angelman, the ASF Family Fund is for. That's what it was created for. And there's twice a year application cycles for funding that could help you get to clinic or anything else that you need.
And so there's tons of resources on the ASF website, and most of them have been created by Ron. So if you enjoyed all that you heard tonight, you definitely want to go on and get those resources. And so I have to, Ron, too, because I need you to know that there is a very large amount of individuals sitting in a hotel in Argentina right now with Adela watching you. So can you wave at them really quick? They're literally all went to a hotel together to watch your session tonight. So you'll have to give them a shout out.
Oh, I know. Can't wait
Our community loves you.
Travel again.
Yes.
We can see you guys.
Yes.
Oh,
Ron, I don't know. So many people are saying thank you. There's no words, right, Liz, on how we feel about Ron and his work. And so, Liz, before I go do last minute announcements, anything you want to add?
Nope. I just want to thank you for spending an hour and a half of your Friday night with us, and all of our community for spending an hour and a half of your Friday night with us.
Thank you, guys. Bye. Bye, Dr. Thibert.
Bye. Bye, everybody.
Thanks for listening to the ASF podcast. If you enjoyed this episode and would like to support us, please share it with others, post about it on social media, or leave a rating or review. And please don't forget to subscribe.